Welcome back to the channel. This is our cat Bean. She is recovering actually from a leg surgery today. So I thought that she would help me talk about recovering from knee replacement surgery. Don't worry, she's going to be fine, but she does have some recovering to do. So this video is about how to have a successful knee replacement surgery. So let's talk about what is a knee replacement, let's talk about problems that occur with a knee replacement, and let's talk about solutions to those problems. Knee replacement surgery is when the cartilage surfaces of the knee have become damaged and rough and they're no longer smooth like they're supposed to be. So what happens is the damaged cartilage surfaces, these smooth surfaces on the top half of the knee, on the femur, these are removed and they are replaced with metal plates like this. The meniscus, the cartilage in the center, is also removed and replaced with a plastic spacer, and just like the top surface here, the bottom surface on the tibia or lower leg bone is also removed and replaced with a metal surface. Once those surfaces of the knee that were damaged, where the arthritis was, are replaced, you would think there would be no pain. Arthur means joint, or arth means joint. Itis means inflammation. Arthritis is inflammation of the joint. In the knee, as we showed with a replacement, the joint is actually removed and a new joint is put in there. So there is no more arthritis in the joint because there's no joint to be inflamed. So what problems typically develop after a knee replacement? Well, first obviously is the pain, and the second is the stiffness. When you're thinking about the pain, realize that a metal joint doesn't feel pain because it's metal, right? Metal is not part of your body. You don't have any nerve endings in a piece of metal. So how can you feel pain in a knee replacement? Well, what hurts is not actually the knee joint, as in the bones and tendons. What hurts is the incision or the scar that remains after the knee replacement. So one of the things that I didn't show when I did my demonstration, but that is important with a knee replacement, is that when the knee replacement is performed, the patella or kneecap is normally in the front of the knee here. It is removed over to the side. They don't cut this tendon, but they move the whole kneecap clear over to the side of the knee to expose this surface to get to the knee. So what that means is the scar that forms is not just a line down the center of the knee like you see on your knee now. The scar is actually all the way over into the side of the knee like this, where the patella went and where they had to open the entire knee up to get to in order to access all of these joint surfaces. It goes all the way from left to right on the knee, and it also goes from top to bottom, from skin down to bone. So if you're a patient and you've already had your knee surgery, let's take a look at your non-operative knee, right? The knee that's still original equipment. So what I want you to do is grab the skin, move it around, feel how that skin on your knee slides and it glides over the bone, over the muscles, over all the things underneath of it. And you'll see that there's a lot of movement there and that it's pretty free. What I want you to do now is use the other knee. Now my knee's a normal knee, but use your operative knee. Push on that skin, try to slide it up and down, see what it feels like. You'll notice that it doesn't move left to right anymore. It doesn't move up and down like it should. So what this means is that the scar has attached all of that skin to the bones and the underlying tissue, and it needs to be moved around and it needs to be freed up again so that that knee will bend and straighten like it should. If you can imagine, if this is all one piece, it's not going to bend very well. So the layers that are in that knee naturally need to be restored and freed up again in order for the knee to bend and move without a lot of pain. There's a great video out there by Gil Headley, who's an anatomy and physiology instructor, that I'll put the link to down in the description. Everyone should watch that video because it's about the fuzz or the scar tissue that develops in our bodies on a normal daily basis. After a knee replacement, that scar tissue is helping you heal. It's knitting your knee back together. But that scar tissue develops into stiffness as it heals. So when you wake up in the morning and you feel that your knee is stiffer than it was the day before, you're not imagining that. Your knee really is stiffer. You'll notice that it's harder to bend and straighten the knee after you've been asleep at night. And this stiffness is the main problem that people experience after a knee replacement. So every night when you go to sleep, that knee that bent, right, it bent and straightened before you went to sleep, now it doesn't bend and straighten as much. So if you were able to bend it this far before you went to sleep, the next day you're only going to be able to bend it about this far. Every day with a knee replacement, just by going to sleep at night, you lose about 5 degrees extension and 5 degrees flexion or bending of that knee. So that stiffness will continue to develop over time. If you don't fix that stiffness, you will end up with a knee that's completely frozen and doesn't bend or straighten. And it's a big problem. Some people have to undergo multiple surgeries to fix that, and even then sometimes it doesn't fix. The pain that you experience is also mainly due to this stiffness. So those two things are related, and they follow each other, and addressing one will actually help you address the other. Let's talk about solutions to these problems. What can you do about this pain? One of the main questions that I get after a knee replacement is patients come in and they tell me, my surgeon told me to stretch. I am stretching. I'm doing this every day. It hurts so much. Why am I still losing motion? The most important thing that you need to understand about a knee replacement is that it's going to feel like you're doing more than you are, and you must measure and determine if you're actually stretching the knee enough to get it to bend. Clinicians, this means you have to measure active range of motion, how far the patient can actually bend the knee on their own without you assisting them. If you're pushing on the knee, it's easy to cheat, and you can say, oh, I pushed on the knee and it got, look, it got 10 degrees further. But if you let go and the patient can't get back to that bent position, if the patient can't actually use that motion functionally, then guess what? You didn't actually gain any range of motion at all. If you remember back to my measurements before, I mentioned that patients lose about 5 degrees of flexion and extension every day. You must gain at least 10 degrees of active range of motion of bending the knee every single day in order to continue to make progress. Remember, you're losing 5 degrees, right? So if you stretch and stretch and stretch, even if you stretch for an hour and you only gain 5 degrees of active range of motion, you're treading water, right? The next day you will have lost that and you won't have gained any motion at all. So the stretching, the bending, it has to be done by measurement. You have to measure that knee after you've warmed up the patient. You have to stretch the knee, and then you have to see them actively be able to bend that knee 10 degrees further. Now remember, stretching is a combination of two things. Stretching is a combination of increasing tissue range of motion and the ability of the brain to allow that motion to happen. I might have the ability to have someone push my knee into bending, but if I can't bend it there actively, I'm not going to use that motion, and I'm not going to keep that motion as I go about my normal daily stuff. So one of the things that's important for clinicians is to stretch the knee, get that motion, make sure the patient can bend that active range of motion, and then at the end of your session, have them use that motion. Use them on the stairs, put them back on the stationary bike, have them use that new motion for a few minutes, feel how much looser it is, feel that that motion is safe and no longer hurts as much as it did, and you'll see much better results in patients keeping that range of motion because they've convinced their brain that yes, my knee now does in fact move that far and I can use it again. When you're treating a knee replacement patient for clinicians and patients for you, I expect in my patients to see full active range of motion by week 4 to 6. A lot of you clinicians are having a heart attack right now because you don't know how that's possible. But if you're measuring and you're consistently getting that 10 degrees of motion every session like you need to, there should be no problem with getting that motion that quickly. Also, what you'll find is when you're doing that motion that quickly, and you get to the 6 to 8 week mark, your patients will no longer have pain. I've seen many patients struggle with pain after a knee replacement for 3 months, 6 months, 12 months, because that scar tissue is so tight and it's not moving and it's still pulling and ripping every time they try to bend the knee. If you get the full motion and you get everything mobilized by 6 to 8 weeks, then your patients shouldn't have that kind of pain. If you can get the full motion, normally they're pretty much pain-free by week 8. So that's the most important and first thing that you need to be concerned with and work on and succeed at in order to have a successful knee replacement surgery and rehabilitation.